So this chapter we are going to go over cardiomyopathy. So cardiomyopathy is a group of diseases that affect myocardial structure or function. It's basically an overall weakened heart muscle. Sometimes we don't know why that heart muscle is weakened because there's not really an apparent cause. So it does require a lot of testing sometimes in order to diagnose cardiomyopathy. Some of the reasons why patients can have cardiomyopathy, as if I said, sometimes it's an unknown cause, but other times it can be caused from disease, like cardiotoxic agents, alcohol, coronary artery disease, hypertension, myocarditis, which is an infection or inflammation of the cardiac muscle, pregnancy, valve disorders. So lots of different things can lead to a cardiomyopathy or an overall weakened heart muscle. And eventually, in all types of cardiomyopathy, patients wind up with heart failure symptoms and cardiomegaly, which is a huge heart. It's an abnormal heart enlargement, but it's the entire heart, not just one of the ventricles, which often we see in just heart failure. So all of these types of cardiomyopathies, which we will go through, will have heart failure symptoms. So the first type is Takotsubo syndrome, which is a Japanese term. So with this type of cardiomyopathy, it's actually an acute stress-related syndrome, and patients will come in with symptoms that really look like acute coronary syndrome. It will look like they're having an MI. They will have chest pain, ECG changes such as ST segment elevations. Their troponins and CKMBs will come back elevated. So what do we do when that happens? Well, they go off to the cath lab. So they will go to have a emergent cath procedure, emergent PCI. And when they get in there, they will notice that there's actually nothing wrong with their coronary arteries that would lead to those specific symptoms. And that is Takotsubo. So it's symptoms that really present as acute coronary syndrome, but it's because of stress that this happens. A really common cause is in the elderly clientele. Remember, we do not have that good of a response to stress. So extreme cases of stress would be losing your husband or your wife when you're elderly, and maybe they were your caregiver and you relied on them for a lot of things. We do see this a lot where an elderly woman or male will come in with Takotsubo, and if you look into their history, it's because they recently had a loss. I like this because it really definitively tells us how much of a factor stress plays in our cardiac well-being. Fortunately enough, many patients do make a full recovery from the Takotsubo, and it doesn't affect them. They just need supportive care, maybe some medications. But fortunately, many times patients don't require extreme circumstances or extreme treatments as the rest of the cardiomyopathy. So Takotsubo is kind of like outside the box, but it's put into this cardiomyopathy category. And then the rest of the different types, ischemic, dilated, hypertrophic, and restrictive, will be covered in the next slides. So ischemic cardiomyopathy is the term given to patients who present with this overall weakened heart muscle, specifically the left ventricle, so that's unable to pump effectively, because of either advanced coronary artery disease or an MI. So that decreased blood flow to the myocardium over time is going to cause this myocardium to become very weakened, leading to a cardiomyopathy. The causes will be very similar to heart failure. So patients are likely to have shortness of breath, extreme fatigue, heart palpitations, maybe difficulty sleeping, weight gain, swelling of the legs. So the same symptoms that we would see with heart failure. Oftentimes, this diagnosis is given for patients who have a very low ejection fraction and extensive coronary artery disease. That's what would make us make these patients be diagnosed with this. So dilated cardiomyopathies is one of the most common types of cardiomyopathies that we will be seeing. So if it's the most common, we'll probably be seeing this more than the rest of the cardiomyopathies on the exam, side note. Anywho, so primarily dilated cardiomyopathy affects adults ages 20 to 60, and it affects both the atria and the ventricles, so it affects the entire heart. Many times it can follow an infectious myocarditis. Some of the different viruses that can lead to infectious myocarditis, just for your knowledge, are like the Coxsackie virus, which is fairly common in children, right? A strain of the herpes virus, parvovirus, just to give you a few examples. Some bacteria can also cause infectious myocarditis as well. So really there's a bunch of different types of things that can lead to an infectious myocarditis. And that's really, a main reason for dilated cardiomyopathy. Other things that can cause dilated cardiomyopathy are alcohol abuse, diabetes, certain medications like chemo drugs can weaken the heart muscle. So it's given the term dilated cardiomyopathy because the left ventricle begins to dilate, but it doesn't hypertrophy. So this very large ventricle actually thins as it enlarges. So you get this dilated heart chamber, so it becomes thinner and therefore weaker, leading to heart failure symptoms. That thinning of the myocardium happens because of alcohol abuse, those are the causes for this, dilation. Those cardiac muscle fibers actually start to break down because of the infection or because of severe inflammation that is going on in the heart that follows whatever caused it. Interestingly enough, there can be a genetic factor to dilated cardiomyopathy as well. Or many times, sometimes, we don't have a cause, just like the other forms of cardiomyopathies. So going over some of our clinical manifestations, you will realize that these are very similar to heart failure symptoms because that's what they are. So dilated cardiomyopathy, patients can either develop symptoms acutely after they have, let's say, an infection, or they can develop more slowly over time. Let's say for somebody who is an alcoholic. Other symptoms that are fairly apparent can be dysrhythmias, ventricular dysrhythmias, right? Because if anytime we change or alter the shape or size of our heart, we're more at risk for dysrhythmias, and that's what's happening. Our ventricle is becoming very dilated and we're stretching out that myocardium, and myocardial fibers are literally deteriorating. So we are at very high risk for dysrhythmias. Other symptoms that are not on here that are related to heart failure and also cardiomyopathy are edema, JVD, weak pedal pulses, right? Because if we have decreased cardiac output, our periphery will probably be pale, cool to the touch possibly. We might have crackles in our lungs. Because cardiomyopathies can be difficult to diagnose, they do require several diagnostics in order to come up with this diagnosis, right? So it's very important to get the patient's history. We get the patient's family history, genetic history to try to see if there's anything, an infectious history, if they were recently ill, to try to see if that could be a leading cause. We would then get an echocardiogram because we would be able to see if patients had an enlargement of the heart chambers, and we would also be able to see if they had an alteration in their ejection fraction or if they had hypokinesis, which would happen in cardiomyopathy because if I have a weakened heart muscle, I'm not going to be moving as well, right? Chest x-ray could give us a picture about cardiomegaly, which is overall enlarged heart. And we would also be able to see if there was any pleural involvement, any pulmonary involvement, which we would see with either pleural effusions, we might see fluid in the lungs, those sorts of things. ECG, we'd want to get a baseline. And also, we'd also want to get an ECG to see if there's any dysrhythmias. since that's fairly common. BNP, that would be present if we had fluid volume overload in our ventricles. So if we have heart failure symptoms or progressing with heart failure, our BNP would be elevated. Cardiac cath would be used just to help rule out any coronary artery involvement. We could look at our coronary arteries. We could also get the different pressures on the side of the heart to see how well our heart is functioning. And an endomyocardial biopsy, which is going in and getting a biopsy of the myocardium to help identify any infectious agents that could have caused this. Our nursing management is aimed really at controlling heart failure symptoms or preventing heart failure symptoms, preventing patients from going into heart failure. So this would include decreasing the workload of the heart by decreasing preload. So we want to decrease the volume that's coming back to the heart, aka diuretic therapy, and also decreasing afterload, so decreasing the force against which the left ventricle and right ventricle have to pump. So controlling blood pressure. So patients would need to follow a low sodium diet, a DASH diet. They may or may not be on fluid restriction depending on their symptoms of heart failure, and they will most likely be on medications, especially ACE inhibitors, to help decrease that afterload. Antidysrhythmics are very common with this, with dilated cardiomyopathy because we're at extremely high risk for dysrhythmias. Beta blockers to decrease the workload of the heart, and anticoagulation can be indicated for these patients as well. If I have a really low ejection fraction and I am nervous about blood stasis within either the atria or the ventricles, I may need to be on anticoagulation, so that may be a medication that would be used. We talked about nutrition. It should be low sodium. They may or may not be on fluid restriction. And they also need to be on a low-fat diet because that would help keep our coronary arteries well, and we would need that, right? Cardiac rehab. So anytime somebody goes into the hospital, we would really want to make sure that if they had an exacerbation of heart failure due to their dilated cardiomyopathy, that we help them maintain the best ventricular functioning that we can, and that is done by cardiac rehab, right? We want to make sure that we are providing an opportunity in an environment where patients feel safe to exercise. VAD pumps are ventricular assist devices, and these are devices that are worn by patients who have an ejection fraction of less than 10%, and it's a device that helps the ventricle pump. An ICD would be indicated for those who have dysrhythmias, specifically ventricular dysrhythmias. Severe enough dilated cardiomyopathy, you can have an ejection fraction of less than 10%, which would put you on a heart transplant list. And unfortunately, the main goal of care for these patients is to optimize quality of life and help patients stay out of the hospital. Unfortunately, they are likely to have exacerbations of heart failure, and it's important for us to discuss with them their end of life goals. Maybe they'll get to a point where they are, tired of going into the hospital every 2 weeks because of heart failure symptoms. What is their goals in regard to, quality of life and end of life? So really involving the family and caregivers. So hypertrophic cardiomyopathy is patients have these enormous left ventricles without any dilation. So they have this ventricular hypertrophy. So there's really enlarged cardiac muscle in the left ventricle and enlarged septum without any dilation. So what's happening is that muscle is actually taking up room in the left ventricle, the room that would be needed for blood. This ventricle is so pumped up and so large that it becomes very stiff and non-compliant. So it becomes very difficult for that left ventricle to relax. This almost reminds me of those bodybuilders, you know how they can't, like their, you know, neck muscles and arm muscles are so enormous that they're unable to like touch the back of their head. This is exactly what it reminds me of. This muscle is so large that it's unable to move the way it needs to, which would be contracting the way it needs to. Genetics play a large role. About half of all cases are genetically based. So, and also it's the most common cause of sudden cardiac death. So if I had a loved one, the loved one being a family member, who died of sudden cardiac death, most likely they would go for testing to rule out or rule in hypertrophic cardiomyopathy. Because if that were the cause, I would be at risk, since half of all cases are, you know, genetically based, I would be at a higher risk of hypertrophic cardiomyopathy. So this is one of those things that is very highly linked to genetics that we want to make sure that, you know, we're aware of. And especially since it's the most common cause of sudden cardiac death. So there was a kid that I'll never forget. I think I told you about him already, but he came in, he had sudden cardiac death, but he survived, obviously, because we took care of him. But he dropped on a construction site, and luckily they had equipment to defibrillate him, and he made a full recovery. But part of his workup, he had a father who also dropped dead, and they thought that it was an MI that he died from, but I don't know the specifics if they ever did, you know, any genetic testing or what have you. But I do remember that before he was discharged from the hospital, they were trying to rule out hypertrophic cardiomyopathy as a cause. So he would have an echocardiogram to see if that were a cause, since genetics plays such a huge role. So 4 main characteristics: massive ventricular hypertrophy, these rapid forceful contractions because that muscle is so enormous. Impaired diastole. My ventricular walls are actually so thick that the amount of blood that that ventricle can hold is severely impaired. In addition, I can have this obstructive aortic outflow, so that muscle can be so enormous that it's actually impairing the pathway through my aortic valve. That muscle is almost like impeding blood flow out through my aorta. So some patients may have symptoms, but many times patients don't have symptoms, right? That's why we call it sudden cardiac death, because they were unaware that they had any cardiac problems. So it's not uncommon that patients don't have symptoms. It's 2 negatives, that's not right. So if I did have some clinical manifestations, I could have exertional dyspnea. I get very fatigued with activity if I had this, because I have a decreased cardiac output, especially with activity, right? I have this enormous heart muscle that is demanding all of this oxygen and blood flow that it's difficult to maintain. I could have angina as well, because this increased muscle mass could actually compress some of my smaller coronary arteries, leading to chest pain because I'm unable to perfuse some areas of my heart. And syncope can result from either dysrhythmias or because I'm obstructing blood flow out through my aorta, because that ventricle is so enormous that it's obstructing blood flowing out into my body, which can cause syncope. Fortunately, diagnosing hypertrophic cardiomyopathy is fairly simple, and echo is the primary diagnostic tool that we can use to diagnose, to diagnose this. So if I did have a family member who had suffered from sudden cardiac death, it's not a really big deal to go in for an echocardiogram. So moving on to nursing management, we would need medications because that muscle is unable to relax and I don't have very good preload or very good fill on that, very good volume in my ventricle. I need medications to help improve ventricular filling, specifically left ventricular filling. In addition, I need medications that are going to help decrease that contractility or the force of contractions, because really that's consuming a lot of oxygen and a lot of energy, leading to activity intolerance. So beta blockers can be indicated for this. Calcium channel blockers, other medications are amiodarones or other types of antidysrhythmics for dysrhythmias. ICDs are pretty much put in just about everyone with hypertrophic cardiomyopathy because they are at such high risk for ventricular dysrhythmias and sudden cardiac death that an ICD would be placed as well. There is a procedure, ventriculomyotomy, which is a surgical procedure that involves literally like cutting away some of that cardiac muscle to allow more ventricular filling or more room in that ventricle. Some nursing considerations or interventions that we need to be aware of is we really need to prevent or make sure that patients avoid strenuous activity because they simply cannot tolerate it, and they avoid dehydration because they already have a low preload, a low amount of blood that's in that ventricle, right? They don't have very good stroke volume, that we don't want to decrease that amount at all with dehydration. So it's really important that patients are not dehydrated. An increase in systemic vascular resistance is extremely dangerous. Hypertension, AKA, is very dangerous, hence the beta blockers and the calcium channel blockers. So we really want to be careful with some of those. Moving on. So our last one that we're going to review is restrictive cardiomyopathy. So this is due to impairment of diastolic filling and stretch. Mainly this tends to affect older adults, and it is the least common form of cardiomyopathy. This impairment of diastole or diastolic filling is not due to large muscle, not like thickened muscle as we saw with hypertrophic. It's just due to the inability of the muscle fibers to stretch and relax enough. To make up with this impaired diastolic filling, to maintain our cardiac output, if we have impaired diastolic filling or impaired volume, right, our heart rate increases. So oftentimes patients will have a higher heart rate, which further impairs our diastolic filling time if we have a higher heart rate, which kind of exacerbates this, and it's this whole cycle that never ends. So some of the clinical manifestations are directly related to our heart failure symptoms. And it's also important that we control the heart rate with restrictive cardiomyopathies because we want to preserve our diastolic filling to preserve our cardiac output. And that pretty much does it for our cardiomyopathies.